Welcome to the Scotlens Delta Bifocal Fitting Guide. So the Delta Bifocal is a GP bifocal lens which makes it really simple to fit, giving good quality distance vision, good quality high ad near vision, effectively a pair of single vision lenses with built-in readers at the bottom. The geometry is based on the Scotlens CC back surface. BIOSes are a wide range of powers available from 680 to 950. It's available in both a spherical, which is prism ballasted, and then a bi-toric. Power range ±20 with 4 sills, reading ad up to a +4, and the reading segment is adjustable. So the standard Delta comes with the reading segment 0.5 millimeters below the HCl of the lens. You can see the distance zone and the near zone, and the markings on the lens are shown. You can customize the reading segment either from a high segment, which is on the HCl, to 3 mm below the HCl. And you can also alter, if you need to, the standard angle of the segment, going out to 180 degrees, effectively a flat executive style, or you can bring the segment down to 120, but standard is 150 and tends to be fine for most applications. So on toric lenses, the segment base will be marked with the asterisk, which is fairly easily visible. And this position should sit at the 6 o'clock position on slit lamp examination. There can be a little bit of rotation, which is acceptable up to about 35 degrees either side. The flat axis from the Ks is indicated by the dashes, and it's the back surface toricity that stabilizes this lens. In a spherical lens, it's prism ballasted, but in the torics, it's the back surface rotation. So the lens can be inserted upside down. So just ensure that your patients are familiar with spotting the dot and placing the dot in at the bottom of their eye. So in a toric lens, the back surface will be rotated based on your Ks that you've supplied, but the segment should still sit at the 6 o'clock position. So you can see the back surface sits offset compared to the front. Now, as with any gas perm, we need to make sure that we've got a lens that's going to be positioned fairly central on the cornea and move quite well. If you've got a lens that is sitting high or low, then it's going to cause kind of loss of performance. So you want to have a BOZR that's kind of alignment to flat fitting. If you keep increasing the diameter to try and lift the segment, it does increase the weight of the lens, which can cause the lens to then drop and sit in a low position. So if you've got a lens that rides high or rides low, that's going to limit the translation of the lens. Now, a lens that rides high or low will not move when the lid blinks. So a lid attached lens, you'll see the lens actually moving up and down with the lid, whereas if it's a high riding lens, the lens will be static on the cornea and the lid will move over it, and that's usually due to the corneal shape and the lid pressure. You can try and adjust the base curve to improve the movement of the lens, but often high riding lenses or low riding lenses that drop, it's often due to the prescription and the anatomy of the eye. And if that is the case, rule monovision out if you're going to have less success with a multifocal lens. And a good rule is generally you want to have a pupil size of around about 4 mm or more, which will allow capture of the near zone and the distance zone with any multifocal. Assessment, best done with fluorescein and a yellow filter, and we want to have a lens that moves a bit like the one in the video, nice movement on blink, and a fairly central position. You can see, if we look at the lens on the left, which is a flat fitting lens, you can see that the lens is actually bridging. So we know it's flat because it's bridging between the corneal apex and the peripheral cornea, and we're getting a sort of barreling movement, a slightly C-shaped movement as the lens blinks. So this is a little bit too flat. Optimum fit, we've got slightly steep pulling in the center, we've got good centration and good movement. And then you can see with the steep fit, we've got hampered movement, so the lens is a bit static, so it won't translate as well as we would hope for. A useful tip is to use your direct ophthalmoscope and look for the red reflex with the pupil. And with this, you can see the movement of the lens and it allows you to keep the illumination quite low with your direct ophthalmoscope, so the pupil size is fairly natural for the room illumination. Now the segment should be positioned roughly on the lower pupil margin. This way you'll get clear distance vision, and then with a bit of down gaze, the lens will translate up to provide the reading vision. If you've got a case in the top picture where the lens is sitting very low, the patient may complain that they can't get the reading, they're not getting the reading when they look down to capture the reading. In which case you can increase the segment height up to on HCL, which would be 0.5 mm higher, or you could also try and increase the lens diameter to force the lens to go up. Of course, if the lens is sitting low and isn't moving, then the translation effect may always be missing from the fit. If you've got a lens that's sitting a bit high, you can lower the segment. Again, you still want to have that lens movement with blink. And as I said earlier on, rotation around about 35 degrees nasal, 35 degrees temporal can be tolerated without causing too much disruption to the near vision. Thanks for watching. You can also find out more information on the other videos about our ProCurve Plus, which is a multifocal lens, and our Revive back surface bifocal concentric design bifocal. You can ask for more information or orders at lab@scotlens.com. Thanks for watching.